So good morning. It's a pleasure to be here. My name is Mark Dobrow. I'm the interim Vice President for Health System Performance at HQO. This particular session is entitled Putting Data in the Hands of Providers Using Personalized Reports to Fuel Quality Care. And I think I've got the clicker in front of me here. So I think in all the sessions that you're going to see, we've got these disclosure slides. And again, in this one, we've got no commercial interest of our panel, so we'll click by that one. The actual session didn't get any commercial support, so we'll click by that one. And we don't have to mitigate any potential biases, so we'll click by that one. As you'll see in all of our work, we've got the hashtag. So for those of you who are tweeting along, please use that hashtag. So what we really want to do in this particular session are two things. The first is really to get a sense from some of the people that are actively involved in personalized reporting and audit and feedback, to get a sense of what they're doing, what's happening in the system, and trying to get a few different perspectives from different sectors in our healthcare system. The second piece is to really get a sense of the evidence base for personalized reporting and audit and feedback, really to get a sense of what the evidence says, what the science says, but also, and this is where the audience engagement comes in, is getting some of the experiential evidence from those of you in the room to get a sense of what we know about personalized reporting and audit and feedback and the things that we don't know. So that's what we're trying to set out to do today. We've got a great group of speakers on the panel. I'm going to introduce each of them as I go right now, and I'm not going to go into a lot of detail in terms of their bios. You can get that in the program or the app if you have the HQT app. But I'm going to introduce them all now, and then I'm going to speak for just a couple more minutes, and then I'm going to call the first speaker up. So our first speaker will be Dr. Michelle Griever. She's a family physician at the North York Family Health Team and is the network director for the Toronto site of the Canadian Primary Care Sentinel Surveillance Network, and is a member of the Executive Committee of Utopian, the University of Toronto's Primary Care Practice-Based Research Network. Following Michelle, we'll have Dr. Tim Jackson. And Dr. Jackson is a general surgeon at UHN in Toronto. And he's also an assistant professor in the Department of Medicine and the Institute of Health Policy Management and Evaluation at the University of Toronto. Following Dr. Jackson, we'll have Nancy Lefebvre, who is the Chief Clinical Executive and Senior Vice President for Knowledge and Practice at St. Elizabeth Healthcare. And then our final speaker will be Dr. Sharon Strauss, who is a professor in the Department of Medicine at the University of Toronto, and also the Division Director of Geriatric Medicine at the University of Toronto. And she's also the Director of the KT program at the Li Ka-shing Knowledge Institute in Toronto. So what we wanted to do, just briefly before we turn it over to the speakers, is talk to you a little bit about what Health Quality Ontario is doing in terms of personalized reporting. And so one of the big areas that we focus on is primary care practice report. This is something that we've done jointly with ISIS and the Association of Family Health Team Organizations and the Ontario College of Family Physicians. And so to date, from April 2014 to date, we've had almost 300 physicians sign up to get personalized practice reports. And we're working with that to refine and based on the experience of working with that cohort, to redesign and refine that piece of work to make it more useful to the physicians that we're working with. We're also looking at other areas to move into in terms of personalized reporting. And one of the areas we'll be looking at next is in terms of long-term care practice, and in particular looking at some work on a project that's actually being led by the Ministry of Health and the OMA in terms of looking at appropriate prescribing. And there's two components of that. One is an educational outreach component, and another is the personalized reporting. And HQO will be working on that latter component as part of our work on personalized reporting activity. Now, I wanted just to give you some of you will have seen this and some have not, but this is just to give you a little bit of a sense of what's in the primary care practice report that HQO produces. You're not going to be able to see this very clearly, but on the right side of the screen is a page taken from a practice report. And so you can see it's divided into 3 sections. The top section is really just a descriptive explanation of the indicator and some of the definitions that support that indicator. The middle part is a graphic representation of the data. And so you can see there, you may not be able to see, but there's 8 time points run at every 6 months. And the intent is to be able to give results back to the individual physician, in some cases adjusted, and also have that comparable to their own practice group, if there's data available, as well as to their respective LIN or to the province as a whole. And so this gives them an ability to look at their own practice, their own individual practice in some context, some comparison to their peers at different levels within the province. And then at the bottom, you can see some of the data that actually supports that graphic representation. On the left side of the screen, you'll see that there's a number of things that we include in the reports. There's 12 demographic indicators, 16 health service utilization indicators, and 13 chronic disease prevention and management indicators. And for the physicians in the room, if you follow that link at the bottom, you could go and you could put in your CPSO number, and you could get enrolled in the primary care practice reports. Now, I really don't want to spend much time on this particular slide or the next. I've only got 2 more to go. But the main point I want to make here in terms of an evidence overview for audit and feedback, and this really relates to some of the work that Noah Ivers, Jeremy Grimshaw, and others did in a recent systematic review, is that we have pretty good evidence that personalized reporting or audit and feedback can have an impact on professional practice. But it's really the details in terms of how we implement the things that we know how to do but don't know how to do precisely, where we need to have more effort and more focus. And so I think that's sort of a contextual piece for where we're at, and you can see some of the more specific things in that in the slide. I think just a last few contextual pieces before I turn it over to Michelle. Really, we're looking for cross-sectoral and cross-jurisdictional insights. We've got a lot of people from different parts of the province here today, and some people from outside the province. So we're really trying to get a sense of, from the panel, coming at it from different perspectives, but also the audience and engagement in terms of your experiences. The second note we want to make is that we really see personalized reporting as one of the tools that we have in terms of quality improvement. All of you are involved in different aspects of that, and so we're trying to position this within the broader QI activity. And lastly, and you'll get a sense of this from the people on the panel, but I'm also hoping that there'll be a lot of input from the audience when we get to the discussion period, is really getting a sense of how much activity there is, but at the same time really thinking about the opportunities to coordinate some of that activity and move this forward so that it makes it an efficient and useful for the providers that are involved. So with that, I will turn it over to Michelle to have her presentation.
So how do I move the slides?
Red.
Oh, green there? Okay. So thank you very much for inviting me. Can everybody hear me? I'm short. So I'm Michelle Griever. I'm a community-based family doctor. In fact, I have patients booked at 2, so I get lunch, and then after that I go back to my office and I look after several people. I've been asked today to talk about accessing and using data in family health teams, and there's some things that made me think they asked me to talk about it in family health teams. There must be a reason for that. So then I went back and I thought, okay, so what do I use in my own practice? EMRs, electronic medical records, now used by almost all of us. Hi, Kevin. It's what, 85% of family doctors in Ontario now use an EMR, the majority in Canada. So we've got bazillions of dollars spent on subsidizing, buying, implementing tons of our time, everything else, billions of dollars, more billions in the US. Does it actually make a difference? If your family doctor switches from paper to electronic medical records, will you be getting better care? I don't know. Is there much measurement? Is there use of information in primary care teams? We don't know. So back in 2005, I told my husband, you're going to be doing a grocery shopping because I'm going back part-time to do my master's. And he said, yes. So there's my thesis. I don't like grocery shopping. There's there's my thesis. I wanted to see whether there was a difference in terms of preventive services, those that were targeted by the pay for performance movement, between those physicians using EMR and those on paper. So we're all getting paid for reaching targets, but if you've got a computer system, do you do better? And here's the result, 0.7% less increase in those using electronic medical records, 0.7% less. Whoop-de-doo, all that money and no difference whatsoever. No difference at all between EMR and paper. Why? I don't know, good question. At the same time, our context, as Mark mentioned, was changing. Right? Before the year 2000, we were mainly over 50% solo family doctors, according to a NICES report. Almost all of us were on fee-for-service. I only get paid when I see the patient at my office and nothing else. Everybody on paper. Today's different. We're all organized in groups. It may not be family health teams, but we're all in what are called family health organizations, et cetera, groups of family doctors with a contract between each other. We are getting paid through capitation. Patient signs up, I get a set amount per year, depending on a patient age and gender, not their comorbidities, not their diseases, just how old they are and which gender. Okay. Everybody's on the EMR. 25% of family doctors are in interprofessional teams, family health teams. We're sort of like your advanced group there. Here's my family health team. That's where I'm going back at 2 o'clock. We've got 71 physicians. We've got 18 clinical locations. We're all in the community, 40 allied health providers, 220 EMR users, 70,000 patients. Sort of this small community, right? But we don't work as a community. We don't work together. Everybody does everybody does their own things because we started as solo. And so we all do things differently, we enter data differently, and as a result, we don't have consistent reminders, we can't build registries. That means we don't know who's got diabetes in my family health team. And our allied health providers, every office is different. They had to learn 18 different ways of doing things, entering data, using the EMR. I don't know if hospitals work that way, but it's probably not a great thing for us to do. Then I started thinking, quality improvement usually is, Dr. Griever, you're not a very good doctor, or you're a very good doctor, you do things this way or that, and here's your results. QI often targets the individual physician. So I get my feedback, my reports, my everything for me, not for my team. But I don't know if industry works that way. My husband, who works for a large paint company, it's not like everybody does things their own way, right? They have standardized data. This is a can of black paint. Okay, you know what it is. They have SKUs and barcodes, right? And they have standardized processes to the degree that they can. The result, if you do this well, as Mr. Deming showed in Japan, was you get larger, systematic, and sustained improvement. Six Sigma. First thing you do, minimize variability. If you have stuff all over the place, you can't move it. If you minimize the variability, you get a chance to move it. Here's the results for preventive services for 15,000 patients since 2007 in one of our groups, and you can see what happens. The first year you start this process, you get a pretty good improvement, pretty much across the board, and then after that, boom, 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 it's sustained. Okay, and that's kind of important. What do I think about HQO? I love data. I volunteered myself very hard. Wait, I get it. And the nice thing that they did is they gave it to me not just for me, my practice, but for my group. And here's the first report I got. And I said to my group, we presented that our diabetic get less of these very appropriate medications to protect their kidneys. Can we do something about that? Province and Lynn on top, us on the bottom. I don't want to be on the bottom. Okay, so let's do something about that. So it was really a signal. We could not identify the patients. We could not figure out what to do about them. So we actually have our own data, and we have our own reporting system as part of CIPSIN, the Canadian Primary Care Sentinel Surveillance Network. It's called the Data Presentation Tool. What do? We said, okay, for every patient who's got protein in their urine, they're at risk of diabetic kidney disease. Which ones are not on the medications that they should be on? 353 patients. Generate an Excel report. Identify the patients. Our data manager does this. Every doctor got their list of, dear Dr. Griever, these are your patients with problematic kidneys potentially who are not on these medication. Do you want an alert in your chart? Right? 33% of diabetics had protein and might not be on the right medication. The data was returned because there's patients who should not be on these medications. They're already on 9, they're end-of-life care, there's reasons not to, the doctor knows. But please tell us which patients should be. Return this to the data manager. We will then put a consistent alert in all the charts, and I just got the data, and within 3 months, 10% improvement. Okay, not that difficult to do. It can be done. So there's a letter in Canadian Family Physician. I think we need team-based data because we are teams now. We need to think about something a little different called population-based clinical care, not one patient at a time anymore. Not only, yes, one patient at a time, but team-based and population-based. We need to monitor quality improvement. I want to know if this has made a difference. We need to plan programs. We have an excellent diabetes education program in my team. Let's find out how they're doing. And standards agreed upon by the team. Agreed upon by the team. We do the same thing, but we all agree. So what do I think? Well, the HQO reports are really useful. It tells me where I am. It can provide very good signals to figure out where I need to go. My group's not as good as the rest. You know, we're all type A's, we're hyper-competitive. It really went over big. Hey, wait a second. Use what you have. So there are several family health teams getting this DPT back, their data back. If you don't have that, then there's other things that you can use as well. You can use your own EMR reports. It doesn't matter. But do try to go to team analytics. I can't imagine in Toyota that every single person on the floor is responsible for doing their own analytics. They are responsible for doing quality improvement. But why are we asking doctors to be analysts? You know, somebody else can do analytics for the team. We now have quality improvement and data support specialists funded by the province. They do analytics for several teams. You know, start doing it, but professionalize analytics. Okay, and then do what you can. If you find that your data is all over the place in your team, maybe the first step is not to try to do quality improvement. Maybe the first step is to try to standardize your data so you can see where you are, and then standardize your processes, and then move them along. So think about what you can do. So start where you are, use what you have, and do what you can. It's really worked for us. Thank you.
This morning. It's a pleasure to talk about something that I really get excited about, and that's quality improvement in surgery. So what I hope to do is talk to you about how data can be used to drive the QI process in surgery, and also talk to you about how cost data can help us potentially save money during the procedures that we do, and actually hope to improve the value that we get out of the interventions that we're providing. So to start off, I just want to talk about the National Surgery Quality Improvement Program. How many people have heard of this in the audience? Anybody heard of NSQIP, the National Surgery Quality Improvement Program? Great, so some of you have, some of you haven't. So basically what this is a data-driven program that was developed to measure outcomes in surgery and provide feedback to hospitals on performance in surgery. And it dates back about 30 years now, when there was a perceived quality problem in the Veterans Affairs hospitals in the United States. In the 1980s, there was the idea that the veterans weren't receiving as good a surgical care as people in the private sector. And so obviously this was a big issue. There was a lot of money put into this program in terms of how do we actually measure outcomes in surgery, how do we get good data in surgery. And over a 10-year period, there was a system of data collection and feedback to providers that was put into the Veterans Affairs hospitals. And remarkably, it worked very, very well. There was actually almost a 1/3 reduction in mortality after surgery in the VA system, and about a 50% reduction in surgical complications. So it was a real hit. And that got the attention of the private sector, so the other hospitals in the United States. And this simple process of collecting data, feeding it back to providers, also proved to be very useful in the private sector. And over the past 15 years or so, this program has spread through hospitals in the United States and Canada. And you can see on the map here that there are many hospitals in Canada now participating in it, including the hospital that I work at. So basically, what has consistently been shown when you get good data and you feed it back to providers using NSQIP is that you can improve care for patients, and you can also reduce the cost of the care that we provide. So it seems to be a recipe for success. The key underpinnings of NSQIP is good data, all right? So what we've learned here, in my experience with the program, is that data is a very powerful quality diagnostic tool. It's how we keep score. It's how we know we're doing a good job or a bad job. And I say good data, and what do I mean by that? Well, really, if you look at the data that's used effectively for quality improvement, it's actually very different than a lot of the data that we have available to us at present. So what I'm talking about is the difference between clinical prospective data used for quality improvement compared to administrative data that we often use for assessment currently. So the main differences are is that clinical prospective data tends to capture more about what happens to patients, particularly in NSQIP. All hospitals are speaking the same language. There's standardized data definitions. It's validated, it's audited. The data collectors are trained. We follow patients beyond hospital discharge. So in surgery, at least, about 50% of surgical complications actually happen after the patient leaves the hospital. So that's very important. The other thing is that it's actually timely, right? So we can actually see how we're doing on a monthly basis. And is quite effective. You get buy-in. People know that you actually are getting information that you can believe, and it's not from last year. So good data is a key to quality improvement. And with good data, you can actually make meaningful comparisons. So you can account for the sickness of patients that you operate on and the complexity of procedures that you do. So here we can take data in a program like this from different hospitals that do different operations on different patients with different surgeons, and you can do risk adjustment and statistical modelings and actually come up with a meaningful site-level quality metric. So what you can see here is you can take apples and oranges and put them to apples and apples and make meaningful sense of outcomes data. And this is extremely powerful because if you are able to make meaningful comparisons, you can effectively benchmark. And these are the kinds of reports that you get back with NSQIP. This is a caterpillar plot, and you can see each one of these dots would represent a hospital, for example, on any outcome that we do collect in this quality program. And for example, if this was mortality, you could see that hospitals doing, on the left side of the screen there, are doing better than expected. So their ODE ratios are actually below 1, so they're doing better, playing birdie golf, so to speak. And on the right side of this graph, the hospitals would be doing worse than expected. And you can see how you're doing compared to other hospitals. And this really excites surgeons. We're very competitive, as was mentioned. A lot of physicians are inherently that way. And you can see immediately how you're doing compared to your peers, given the patients that you're operating on and the procedures that you're doing. So with this kind of benchmarking, you can actually drive a cycle of continuous quality improvement. So with high quality data, you can make meaningful comparisons. You can benchmark to other hospitals, and really you can see where you're doing well and where you need to improve. And where you actually find out where you need to improve, you can do targeted quality improvement. So you can actually sort of really streamline your QI processes. And I want to show you an example of what we did at our hospital. So one of the types of surgery that I do is bariatric surgery or weight loss surgery. And in 2012, we began participating in this program. And on one of our first reports back, we noticed that our surgical site infections or wound infections after surgery were actually higher than expected compared to all the other hospitals. And in this program, it's actually about 600 other hospitals we compared ourselves to. So my first reaction is, well, you know what? I work at a downtown hospital. My patients are sicker, so I would be expected to have worse outcomes. But I can't do that because of that risk adjustment process, that way of accounting for complexity of procedures and complexities of patients. So I actually believed this data. I believed it was apples to apples comparisons, and I learned that I had a problem in SSIs in 2012. So when we got that data, as a provider, we wanted to think of ways to fix it, and we got a quality committee, and we looked at ways we do things in our operating room. We changed a few things, and what was remarkable is with the timely feedback provided by the program, you could see this is second quarter of 2012. Looking at the surgical site infections down on the bottom there, we actually were able to make measurable improvements over an 18-month period, bringing our infection rate to sort of 2.5% down to 1.8%, and that doesn't seem like too much, but it's actually a significant reduction. We also looked at things like readmissions where we had issues as well, and we noticed big improvements in our overall quality of care, and it was all fueled by the data that we got from this program. And you can see here, that's the 18-month period. And now this is the risk-adjusted report that I mentioned to you earlier. And you can see that high outlier status. And the beginning of our participation was actually moved down to as expected. And we were actually, I'm happy to say, we're sustaining this improvement, and we're continuously collecting data. So we'll know if we do develop new problems in how we care for our patients regarding the SSIs. So clearly, to me, this is a strong example of how if you put good data in the hands of providers, you can actually move the quality needle and make a big difference. I mentioned I wanted to talk about cost briefly. At the same time, we collect a lot of data on quality. We also collect a lot of data on cost. And frequently, this was fed back to me. I couldn't make much sense of it. So we thought we'd develop a way of summarizing it for surgeons and feeding it back to them in a similar way, like the quality data was, to see how we're doing on the costs of our operations. So we developed a relatively simple computer program that just sort of read off the printout, the PDF that's made in our cost centers, and made sense of it and emailed it to surgeons every 2 weeks. And we just use the traffic light system. That's something that at least I can understand. And if you're red, you're higher than the group average. Again, we're benchmarking across our peers. If you're green, you're below average, and so forth. And you can see here, when this gets emailed to you, we also made it so you don't need to open anything. It just comes right on the screen. So no effort, really. We confirm that people looked at it, and this is an example of one of my cost reports. So all of a sudden, I noticed that I was somehow costing a couple $100 more per operation than my peers doing the same operation. So we started trying to understand where we were spending money on different aspects of our disposables and things that we use in the operating room. And sure enough, just by feeding data back to providers, we were able to reduce the cost of our operations over a pretty short period of time. So this is just a pilot. This is about 5 months in, but we're already saving a couple $100 per operation. And this is an example of gastric bypass and sleeve gastrectomy, 2 specific weight loss operations. But this would end up saving thousands and thousands of dollars for our hospital over time. So if we're able to improve quality and cut costs, we can really improve value of the care that we provide. And these are 2 strong examples of how if you put data in the hands of providers, you can actually really make a difference. So in summary, I think learning with the NSQIP program after the last couple of years, I really believe that surgical quality is measurable. It's something we should be measuring. When you have high quality data like that generated in NSQIP and you feed it back to providers, you really do give them an opportunity to improve care, and it works. I think it's a triple win. So it's good for patients, they get better care. It's good for providers, we get an opportunity to improve the care that we provide. And it's also good for payers, it's good for the system, it saves us money. So with the cost data and the quality data, I think there's real opportunity to inform future health policy as well. So thank you. All right.
Good morning. So I'm here to come at it from a little bit of a different perspective, and I'm looking at what's the importance or how have we actually gone about putting data in the hands of clinicians within a home care environment, and not just clinicians, but all levels within the organization. I think the first part of that I would share with you in terms of our journey of putting data in the hands of clinicians and providers is that it is a journey, and it is a long journey. It's not an easy one, or it ain't easy, and it's certainly not for the faint of heart. I think the most important thing when you're going down this journey is to take a look at the context within which you're trying to move forward with data. And so when we began to look at our context, it's a bit unique in terms of we're a national home care provider, so across the country. We have 8,000 staff of all different levels in terms of personal support workers, we have nurses, and we have all of the 5 disciplines in therapy. We look at providing 18,000 visits a day across the country, and we have highly mobile, geographically dispersed staff who travel approximately 40,000 kilometers a day. So collectively, they travel around the world once a day. So we begin to look at this unique environment and say, oh my gosh, how are we actually going to implement a system of quality audit and feedback within this kind of an environment? In addition to looking at our data systems that were created many years ago for actually getting people to the doors, not for collecting data and quality information, in looking at the multiple reporting requirements we have just in the province of Ontario alone, never mind across the country and what that all looks like. And unfortunately, but in home care, we are primarily continue to be paper-based. So we're saying, okay, how are we going to actually attack this challenge, and what are we going to do? So let's look at building on the strengths within the system. We know that we have mobile workers who are independent, they're very agile, they're resourceful. We want to understand what motivates them, what do they want to know, and typically within our world, like every other healthcare world, people who are providing care want to do a good job, and they want to know that they're doing a good job to improve patient quality and patient care outcomes. And we needed to really understand what was the workflow and how did people go about their work, because I have found in home care that every one of those 8,000 staff works in a different way, and there's not much standardization. You can't standardize care in a person's home or standardize the approach, but you can certainly standardize the data that you do collect to actually inform the process. So we decided to really look at building on the strengths and utilize technology with the understanding of the workflow so that we could begin to get our mobile workers collecting data right at the point of care, incorporated into the work that they were doing, but also to be able to report back to them on an individual basis the feedback mechanism process. And I think that although Michelle talks about, and it's very valid in terms of looking at how can we get team data back, we also wanted to drive it right down to the frontline clinician so that they could understand what they were doing and how that was impacting on the client. What we did learn in terms of our process is that, as like anything, it's critical to think about where you're going to begin the process of the journey, because where you begin highly influences, and where you begin to design highly influences the point at which you end up and where you're going to end. And so if you lead with data and you get caught up in the data and how much you can collect and how much information and where you're going to get it from, then you put technology on top of that, you can run a bit amok, because there is a tendency to over-collect the data, collect too much, and then it's left for the clinicians to sort through and sift through the data to make some sense of it. And I think, Tim, as you suggested, we can't be expecting our clinicians at the front line to be sifting through and analyzing reports, let alone our program people. We certainly need to be having health quality analysts on board to be doing that type of thing and be feeding and pushing and pulling information in that respect. So it frustrates staff who are asked to collect a lot of data or too much data because it's often not looked at or not used. I think sometimes as health service analysts we fall in love with the data or we get infatuated with it, when in fact then we think that the data or the technology is driving the improvement when actually the data is to be enablers. So you can't lead with data, and we have to be careful not to get infatuated with what we actually possibly can collect. Instead, what we've suggested, instead of getting infatuated with the data, that we should be wedded to the uptake. So infatuation in terms of getting carried away with the data, we don't think clearly when we're infatuated, it's often short-lived. Instead, we should be looking at getting married to the data so that we have a deeper understanding of the data, we have a better communication process, we know that we're in it for the long haul, that there's ups and downs and it takes work. So that would allow us then to take a look at things in a bit of a different way, select a few meaningful measures and indicators, focus on it, and drive it home for the long haul. Again, coming back to the concept of the power of one of the other things that we learned about is in terms of the data that we do collect, that it has to be meaningful data. It has to be relevant for the clinician, and as I said earlier, the clinician has to feel that if they're going to change their intervention or change a practice, that it is going to impact on the data or the outcome and the information that we're collecting. And we talk about giving our data, we talk about the power of one, and we kind of apply that approach to the data in terms of the difference one person can make, so the power of one. So if we apply that concept to data, it is personalizing the information in terms of a patient's story and the story of the patient that the clinician is working with, so that there's truly resonates and gives meaning to what it is that we're doing. So once we've figured out what the data is, we're wedded to it, we've figured out how to commit to it, just as important in terms of identifying what that data is also in terms of how we report it back to the clinicians. And so what we did learn through a little bit of a study that we did on audit and feedback is that we need to look at the target audience in terms of who we're creating the reports for and make those reports meaningful and relevant to the target audience. So We have a number of reports within the organization, and these are just some examples of them. So in terms of looking at our wound healing rates and how we're progressing in terms of percentage of wound heals and the rate of healing, we looked at creating reports with a lot of detail at the clinical level so that the clinician can take a look individually at the patient, but also that the supervisors could be taking a look and the managers can be taking a look at the variances within that at the detail level and drill down and follow up with the various clinicians accordingly. We also then have rolled it up, so we're looking at, again, a wound care report, and this level report is more of an aggregate in terms of looking at regions across the country that often our regional directors or vice presidents, SVPs use, and we also use the traffic light because that's fairly simple in terms of giving a quick overview glance that highlights for the management staff where they need to look further and where they need to drill down. In addition to that, we've also created a dashboard for each of our programs as well, so that it's more of a pull strategy, but at any point in time, any of the program clinicians right up through to the senior vice presidents can go in and take a look at the dashboard and get a bit of a trend over time so that they understand how things are continuing to improve or not to improve. And it also, in this dashboard, there are also opportunities for benchmarking and comparison. And we too have a very competitive environment of clinicians and regions who also want to see themselves raising it up. Lastly, we've also created what we call as a program matrices for the quality committee of the board and for the board. So instead of having them drill down into the detail level of the data, they want to be knowing how successful we are in terms of our programs and the difference that we're making. So we've rolled it up into what we call a matrix where we're looking at how are we performing in these programs? Are we at a satisfactory level or are we at a premier program level? So once we developed the process, engaged our staff, just as it takes a village to raise a child, it also takes a village to embed the process from a sustainability perspective. Everybody has their own roles, their responsibilities, right from the frontline clinician who creates the indicators, who collects the data, who looks at the data, who writes the reports, where do the reports go, what do people do with the reports. And ultimately, then, what does one do with the data in terms of driving the quality home? So this slide just depicts the process that we put in place from a quality perspective, identifying that it is, in fact, a process. It's a bit of a living lab. One leads to the other, and it's never really ever over. This last slide that I wanted to show you in this kind of living lab environment, and not that you can probably read it, but really it just depicts the complexity of the process within an organization and the need to identify key accountabilities and responsibilities for each of those items in terms of who creates the indicators, who collects them, who measures them, etc. And that it is a very complex process, but it's clear to take a complex process, break it down and make it as simple and transparent as is possible so that everyone knows what their role is, what their responsibility is, so that you have the whole team embedding and moving forward from a sustainability perspective. So in summary, I think the key learnings from our journey have been the importance of understanding the context in which you're moving forward with a quality and audit feedback process. Know the workflow, know what's important to your clinicians. You cannot lead with data, don't get infatuated, get married to it. Well, you could be infatuated and married. And the power of one, customize it, make it meaningful and relevant, and then it does take a village, so you need to have transparency and clarity about the roles and responsibilities of everyone in the village to raise the child or to actually embed and sustain the use of data and feedback. Thank you.
Good morning, everybody. I'm Sharon Strauss. So I have the pleasure of being able to summarize some of the key points that we've heard this morning. And just to start off with, I just wanted to congratulate my colleagues. I think you guys are all really fantastic and doing amazing work, and very jealous about some of the data that you have available that we don't have. So I'm gonna just summarize with a few points. And I said at the beginning when we first talked about the session that actually Noah Ivers should be here, because Noah Ivers, I don't know if he's in the audience, he was here earlier today. Noah Ivers has done a lot of the work in audit and feedback and is a real star. And in fact, won the CI Charter Rising Star Award for some of his work. And this is some of what Noah found, and I don't want you to read the details, but he's really done a fantastic job in highlighting the best practices for audit and feedback and looking at the very rich data that's available. There's more than 140 trials of audit and feedback. It's an amazing body of literature. And Noah's gone through it all and helped us identify what are the key components. And so I would really encourage people to have a look at some of his work. One of the things that Noah identified is around the importance of having access to good data. And we've heard that from our colleagues today as well, that both Tim and Michelle highlighted how important it is to have good data. Some of the data that we think we're going to have access to and we think is going to be good isn't necessarily as good as what we hope. And so one of the examples I wanted to mention is a project that we recently been doing that Barb Liu led us on. She's based at Sunnybrook Hospital, and it's looking at mobilization of older people admitted to hospital. So you guys know that once we admit somebody to hospital, the first thing we do is we put them to bed. And often we don't think about getting them up again until we're starting to think about discharge. So people are upright on average only about 35 minutes a day once they get admitted to hospital. So maybe they get up to pee, and that's about it. So it's a big challenge. And so for older people who are admitted to hospital, they can become profoundly deconditioned during their hospital stay. So we focused on an early mobilization strategy of older adults admitted to acute care hospital. And our outcomes we were interested in are mobility. We wanted to see, could we mobilize people? We also wanted to look at length of stay, discharge destination, and falls. Because when we started implementing this strategy, the biggest thing that people kept saying to us is, we don't want to mobilize people because we're going to make them fall. And that's true, right? If I mobilized all of you, I'm going to increase your risk of falling because you're upright. So you are going to be at increased risk of falling. But the consequences of being stuck in bed are much more significant. So we wanted to look at falls, but our primary outcome was mobilization. This data is not routinely collected on our patients. So we had to come up with a way of measuring this. And so that's, again, one of the challenges. If it's not data that's routinely collected, how are you going to measure it? And how can you do it in a sustainable, reliable, valid fashion? So we did show over 15,000 patients. We were able to increase mobility. In terms of looking at other outcomes, length of stay we could get from our decision support within our hospitals. We also asked for decision support data on falls and on discharge destination. And this is an example of how data that gets reported at the hospital level, and it does get reported as part of various report cards that are required. It's not very accurate data. So out of the 14 hospitals that we looked at for their data on falls, when we compared the data to chart reviews, so we did chart reviews on every one of these 15,000 patients, the data did not coincide at all. So we weren't able to use the data from decision support. Similarly, discharge destination data, if you access it from the hospital system, it's not very accurate. If it says, in about a third of our patients, it said discharge destination CCAC. So what does that mean? Does that mean that they went home with CCAC? Does that mean CCAC assessed them for potential admission to long-term care? So it really wasn't clear. So again, that's data that we weren't able to access. So really highlighting how important it is to have access to valid data that's useful in your particular context. Other key component to keep in mind is just giving people the audit and feedback isn't enough. Just giving people that report isn't enough. We have to be able to also give our colleagues an actionable message. So what is it that we should be doing if we're not meeting our targets? And how do we do that? So how do we frame that to people? How do we make it so that it's easy for people to do, that it's understandable? Similarly, how do we prioritize the different messages? Because if we're getting audit and feedback reports on 20 different things, how do we prioritize that? And how do we work with our team to be able to do that? The third challenge that I think we have in this area is lack of knowledge is not the most significant barrier. So if we just give people the information, that's not going to be enough to fix the issue. If we look at the literature on guideline implementation, there are more than 275 barriers to implementing guidelines just at the level of the physician. That's not at the level of patients, other providers. That's just at the level of the physicians. So it's a huge issue, and so just providing people with data is not going to be enough. We did a study recently looking at how long would it take a primary care clinician to implement the top 8 chronic disease guidelines relevant to people over the age of 65? And I'm sure Michelle's not surprised by this, that it would take her 266 days just to implement the recommendations in those guidelines. That's not counting if you had to act on those recommendations, so if a test was abnormal. So how do we place this data in context with an actionable message and make it feasible for people to do? So I'm probably sounding really depressing now, right? That it's like really challenging. But one of the solutions is that we have to target groups as a group. So not just the clinician, we have to go broad and think about who are the members of our healthcare team in the context that we're working with. So for example, we did a project, this is something that Andrea Trico led us on, looking at what are the KT quality interventions that are effective for people with diabetes. And so these are the outcomes that we looked at. And I really wanted to highlight that the ones that are most effective, so the ones that actually you see the biggest effect on hemoglobin A1C, so to the right of the screen where it says favors intervention, are the things that are targeting the team and the patient, not the things that are targeting the clinician by themselves. So we really need to push on targeting the broader team, including our patients. So why not send audit and feedbacks to patients? So think about what are the other members of the team that we could be engaging in this. So all of these interventions are effective, but we see a bigger effect with team-based or patient-based changes. We've seen this now in 4 different reviews that we've done. This is another one that came out recently on frequent users of the healthcare system. We saw the same thing. Interventions that target the team and the patient have a bigger impact than if we target the clinician alone. And then finally, the last thing I wanted to mention is we always have to think about sustainability. And I always worry when we start off with implementation interventions and we don't think about sustainability up front. So how are we going to be able to sustain the intervention? How are we going to be able to continue to provide people with high quality data? How are we going to be able to continue to support people on the implementation of what they need to do to achieve the appropriate quality of care that they want to? So this is one of the things that I see as a big gap in the current area of implementation. Most of the work that's being done looks at very limited time periods, 2 years, 3 years, not much beyond that. So I would really encourage people to think about when we're starting some of these projects and looking at using data, how can we sustain over time? So how can we ensure that what we're doing today, we can still monitor on an ongoing basis? So those are some of the challenges, and I look forward to hearing from the audience about what you see are the challenges and some solutions. So thank you very much.
You can sit in the order that you were in, and they'll turn your mic on the appropriate way. All right, so we've had 4 great presentations, and it's really nice to hear some of the expertise that we have on the panel. So now I'm turning it over to the audience. I'm sure there's going to be some questions for this group on personalized reporting and some of the things that you've heard today. So don't be shy. We've got somebody in the back there. Sorry, the lights are bright. Go ahead. If you could just state your name and the organization that you represent.
Hi. Is on? Okay, great. Hi, my name is Laura Silver, and I'm the project manager for the Quality Management Partnership, a special service area colonoscopy. And I found this really interesting because in our journey to create a quality management program for colonoscopy in the province of Ontario, our expert panel developed indicators that would be used in an annual quality report to feed back to the providers. So it was one of the questions that I had is that when we talk about getting those reports back and we talk about, well, we can identify what it is we might need to improve upon, we can see an indicator that we're falling short on. Did any of the panel members and their teams experience a question of the how? So was there enough resources in the system in place that if you had a problem and you needed to improve your quality in a certain clinical skill, is there a course or a master class, or is there a SWAT team that can come down into your facility and improve that? So I wondered if anybody felt that was a challenge, because it sounded like everybody was really able to solve a lot of those quality issues in-house, and I thought that was really interesting. And then the other question I had is, were any of the indicators based around patient experience or patient satisfaction? Thanks.
Who wants to take that on?
So, well, I mean, I could start. I mean, in terms of a SWAT team, I guess we probably didn't have a SWAT team, but in terms of identifying, we did identify early on in terms of Sharon's point around how are we going to sustain this and how are we going to make changes, what are we going to do with the data. So we're clear about whose responsibility and accountabilities were those, and there was a team effort. And it was interesting because when we first started, if it had to do with clinical quality, it was always the perception that, well, it was the program lead of the clinical program. It was her job to influence, 500 clinicians to practice differently to get a different outcome. And the, let's say the manager in the area would see that they didn't really have a lot of accountability for influencing that. And so we spent some time talking about really what are the roles from the frontline clinician, the clinical practice coach, the supervisor, the manager, and the regional director. Everybody has a role to play in improving the quality. So looking at the data and making decisions about what needed to be done and moving forward on that level. So that's one piece. In terms of the patient data, we do in all of our programs collect patient satisfaction and patient data. But one of the things that I thought was interesting, Sharon, that you mentioned was how do we engage, because the best outcomes are when the person or the patient themselves are involved in making the changes, how do we involve them and get them to see the data? And so in our wound care program, we actually utilize the data, and our clinicians have it at the bedside where they're taking pictures of the wound, they're measuring it. So often patients can't even see their wounds or where they are at. So giving them the data in terms of even at a very millimeter level how the wound is improving, closing, healing, made a big difference. And so interesting enough, it did also raise our satisfaction rates in those programs because they were more engaged with how they could themselves impact on their own health and improvement.
I mean, from my perspective, I think the availability of QI support in hospitals is variable, and it depends on the level of buy-in, in that particular institution. So I think some hospitals are better than others when they do get the feedback that they're not performing well in an area. In some settings, there are people who can help support the QI process. In other settings, it's sort of an organic, provider-driven process. So I think it's an area for improvement, and obviously that's how this works. You have to do something with the data. So that's an area where we really need to really help providers, empower them to change.
Sure.
So just to that end, I think that never underestimate how much time and energy it takes to kind of fix the problem and to identify what might work and what to implement. And there is a body of literature around what interventions might be effective and what ones might not be effective. But I think that, and I would encourage you, if nobody has seen the database RX for Change, it's a freely accessible database that outlines kind of what interventions might be effective. I would encourage you to have a look at that. But I would really say the other thing too is being able to match up what are the barriers to the uptake of the information and using that to develop your implementation strategy. But it does take a huge amount of work. I really appreciated your question around patient-centered quality indicators because there's been less work on that aspect, and we're doing some work. Tom Stelfox, who's a critical care physician in Alberta, is leading us on some work looking at quality indicators in trauma care, for example. And we looked at trauma indicators from around the world, and we couldn't find any patient-centered quality indicators. And that's led to an initiative that he's leading to try and develop those. So I think it's a big area that needs to be tackled.
Yeah, we did provider-level indicators for an annual quality report, and then we're also doing a facility level report, and it has patient experience indicators on it. Thanks very much.
Michelle, did you have anything?
So one thing in industry, they use consultants from the outside or they use inside. And the same thing for you, your SWAT team. Do you want to have it from the outside because they carry a lot of expertise, but they might cost you a lot and you don't build your capacity inside? Or do you want to use your inside? You learn. Might not be as good the first time, but then you're going to develop your own. Right? We don't have much in the way of patient satisfaction. I think Health Quality Ontario is driving. What I have in my waiting room is a box that says put feedback. And what do people complain about? The parking. Right? You said, oh, haha, the park. But maybe that might be a barrier for some people. It's $4 for the practices, family practices inside the hospital. It's $20. Maybe we should be doing more non-office visits. So, I don't know. It's a start for us, and you start where you are. It's parking.
Next question.
Hi, everyone. First of all, congratulations on all of your projects. I'm in that stage of infatuation when it comes to
nice to be
when
there.
it comes to data, for sure. My name's Anthony Mohammed. I'm the senior specialist on equity and community engagement at St. Michael's Hospital. And my question is around applying an equity lens towards the various projects that you're all working on. So one of the things that's happening across the Toronto Central is all hospitals and a number of other agencies have begun collecting patient sociodemographic data in order to apply an equity lens to selected health outcome indicators, not to develop new indicators, but to apply that equity lens, and in order to better track and reduce health disparities. I was wondering if that was considered. I know that we get lots of data from our agencies to look at all the other dimensions of quality, but equity is a very tough one to kind of grab and then apply. So that's my question, but thanks a lot for your presentations.
Anyone want to start with that one?
So for us in primary care, we don't know who's poor. And again, it goes back, should we know that? Is poverty a vital sign? Is it something that we should even look at? And you ask 10 family doctors, you're probably going to get 8 different answers. And the answer, I think, is yes, because if you're poor, maybe it's a heck of a lot more difficult for you to manage your chronic condition. You may have difficulty with transportation. You may not have access to grocery stores. I don't know. So the challenge for us is, okay, how do we collect data on poverty? And we've started doing so, but I'm not going to tell you how.
At least from my perspective, in our data collection program and our quality program, it's something that's lacking. We don't do enough of that. In fact, there are some barriers to collecting that information in our, to protect personal health information, at least in our benchmarking process. So that is allowed in the United States, at least within this program. But in Canada, in our environment, we're actually not allowed to collect that for benchmarking.
Yeah, in home care, we don't collect that information. I suppose if we're looking at certain populations in terms of changing a program in relation to a population, it may be the next level down in terms of when we apply it, but it's rare.
Mm-hmm. Yeah, no, I would agree, and I think that it's again, we talked about kind of some of the last frontiers in terms of being able to collect accurate data, and you've highlighted that's an area that, and as Tim said, in a lot of our projects, we're not allowed to collect that data, so we have to be really careful.
And it actually limits our ability, at least in surgery, to risk adjust things appropriately, because it's one characteristics of a patient population of a given hospital that I think really does make a difference, and it's something we just can't account for. So I think it's a deficiency.
Get the next question.
Hi, I'm Laura from Women's College Hospital, and I'm working on a project that engages and supports solo primary care physicians in the community. And it's been a really difficult group to just get engaged and get involved in the first place. And we've wanted to sort of provide them with feedback, but we're concerned that there's going to be a negative aspect associated with it. Like we're accusing them of being bad doctors or they're not doing a good job. And I wondered if you had experienced that and if you had any advice.
So are solo family doctors bad doctors? The answer is no, of course not. But sometimes they're feeling very isolated. I don't know how you engage them. One of the pieces maybe, do you ever feel that you're alone and you've got this mountain of paper and it's unsurmountable? Here's how we might be able to help you. We're going to link you with X, Y, Z. It's a conversation. I think all of us like to feel connected. One of the things you might be able to sell is connections.
So we have we have kind of tried to connect them with the project. They have one number to call to access, but we have hospital data about their patients' use, and it's how do we feed that back without making them feel like they're bad doctors.
I think one of the most important things is to involve them in the process, and from the surgical quality stuff I was speaking about, that's one of the main reasons it's been so successful. It's been a provider-driven program. They're involved on what's collected, what the definitions are, how it's collected, and they really feel invested in the process. So I think it has to, the data and the whatever program you're starting has to involve the providers from the ground floor. I think everybody, at least that I'm aware of, wants to know how they're doing, and I don't think that's the real issue. It's just how it's done, I think is really important.
And there is literature on how to frame messaging, and in particular, I don't know if you've reached out to anybody from Human Factors or User-Centered Design, but they're excellent at helping us try and frame things so that it's not, it doesn't seem that it's the name and shame kind of thing that people want to steer clear of. So that's, I think, a solution that you might want to consider if you haven't.
Next question.
My name is Paul Cooligan. I'm a family physician in a rural area in Eastern Ontario, and I'm in a what's called a FO, or a family health organization, or perhaps a family health team light version. And I wanted to make a comment and a plea, and perhaps ask Dr. Griever's opinion. I do some hospital work as part of my work, and when I'm in hospital, my medical records department, we collect data in terms of all the diagnoses involved. When I'm in a long-term care facility, we collect data usually for funding, and it's usually some variant of the MDS that they use. When I'm in my practice, I provide data every day through my billing and my diagnostic codes. Those codes have been largely ignored and abused by physicians and by the insurance, OHIP, who record all these things. And there's a huge amount of data that would be potentially valuable, at least in my opinion, if we updated that system and made it somewhat of a requirement for people to provide good data. And when I listen to what you say about the difficulty of collecting, and really the message I heard was garbage in, garbage out, if you do good stuff. And I just wonder if I could make a plea to HQO or to the panel about whether you think that would be a good approach to update that system.
So in the UK, they have this big project, Quality and Outcomes Framework. One of the things they pay for is kind of better data. Here's your list of patients with diabetes. They have some auditors. So should we move away from pay for performance, which kind of, I don't know, works a little bit maybe, and sometimes doesn't, to pay for data, which is an earlier step, but also an important one. That's when. So what are the incentives for us to enter and provide good data? Because right now there's limited in terms of finances, right? We don't have a lot. So make sure the incentives are aligned. The second thing is the many data silos of the patient. Diabetic patient with diabetes, go see an optometrist, one silo, go see the family doctor, another silo, go see a specialist, go to the hospital. So is there a way to break these silos so that the patient follows the data and the data actually flows to the most appropriate, all the appropriate providers within a circle of care at the right time, and including where it's used to support health system use, the big system. I think we need to have a renewed conversation about privacy. What is stewardship? What is appropriate privacy? What do patients think about privacy? Because we've sometimes heard that privacy is actually a barrier to better care. Should it be? Should it not be? Well, as a society, we probably should have a conversation about that so that you have the data with your patient's consent, with their agreement, with their input, at the time that you can use those data to provide the best possible care together with your patient. That's what I think.
Yeah, Michelle, I think you raised a really interesting point around privacy and it being a barrier to data, because I think that in most cases, it's us, the clinicians, that are more concerned about the privacy and protecting of the data than it's actually the people with the data. And I think, we talk a lot about EMRs and EHRs, maybe looking at person-centered records. There's an interesting study going on in London right now where they've given, 400 or 500 people access to iPhones to be inputting data, with the agreement that the data will go into the hospital system. They've never had so much data in terms of real-time treatment, intervention, outcomes, how are people feeling, to actually inform better care and better health outcomes than they would with their own records, and more truthful data as well too. So I think it's an interesting concept that, as you said, from a societal perspective, we need to be having a conversation about.
Okay, I think we have time for one more question.
Hi everyone, my name is Cashin Fitzsimons. I'm a quality improvement lead at Dundurn Place Care Centre in Hamilton, Ontario. Thank you all for being here today. Your projects are inspiring. It's great to learn from such experts in the field. My first comment is related to the comment on equity. And I feel I'll just get in my soapbox here. The social determinants of health are huge, huge factors in understanding broader health outcomes. So kudos to you and what you're doing at St. Mike's. My further comment to further this discussion, in the long-term care sector, what we're doing is tracking call bell response times. So if I'm a resident and I press a call bell, that is sent right to a computer system where I know down to the second how long it took a staff member to respond to that. And we're now synthesizing that with risk of falling, if a resident has worsening incontinence, different health outcomes, and integrating all of this into the way we approach this, so much so we do this on a weekly basis. Our nursing staff, our PSWs, they're all on board. The one challenge I'm having as a non-clinical staff member in this home is integrating our physicians into this process and getting them excited about the data we're collecting. Mind you, call bell response times may not be the most relevant, however, they certainly have an impact on the health outcomes in our home. As evidenced by risk of falling, you'll see we've actually been able to track down to the very minute someone pressed a call bell, had an extended wait time, and experienced a fall. So we can see that cause and effect. How, in your expert opinion, how can I get my physicians at this home excited about this, excited about participating in this quality side of this home? Thank you.
Okay, I'll take a stab at it. I mean, basically, physicians will tend to respond to their peers. So if you have a well-respected peer that says this is an important project, here's, I know it's kind of a little bit difficult, but here's the outcome. Your patients will fall less if they're answered, it's important for us to do this and we're going to measure this. They might be more likely to do it. The change agent, somebody who's going to help the physicians, who might be a respected administrator, who's going to sort of offload some of the work. So there's probably a lot of literature in change management. But basically, if you can get a physician champion to help you, your odds of success are somewhat better.
We definitely agree with that. And I think you got to create a burning platform, so you really have to make it clear why this process that you're looking at, how it will improve care, what it's linked to in terms of outcomes, and get someone who can really champion it and get talking to all your physicians. I think that's the best advice I would give.
Yeah, I think the last piece is what's in it for them. If they're going to spend the time and the effort in it, what's in it for them?
And telling the story, like why is it important, and so why is it important to them in particular? So I think that stories are always really very valuable, and if you get, as Michelle and Tim said, if you find a physician champion, I think that's the place to start. But then you also have to be able to tell the story of why it's important.
So I just want to wrap this up. I think we've had some great presentations and some great questions from the audience. I don't know if this is still, I guess that means it's not working.
Yeah.
It's over.
There we go. So I just wanted to wrap up in saying we've had very interesting presentations and some interesting questions and responses. I think if we look back to the learning objectives that we had set out for this session, one was to get a sense of where the science is and where the experience is. And I think we've heard a lot about that. And then the other thing was to get a sense of what's happening in different sectors. We've got some really great examples. And I think, if we look at some of the vision for the road ahead, it's really about the challenges we face with sort of implementing what we know and building on what we know to go forward. There's a lot of challenges to make this something that's easy to use, that's routine to use, that's something that can really be a factor in improving the quality in our system. And so there's just a few points there. I'm not going to go through them directly with you, but I think in a sense that summarizes where we were at today. So I thank everybody for attending the session. If we can give a round of applause for the panel, I think it was great. And I should know where we're going next, but I think it's probably lunch. Good. So thanks, everybody.